Welcome to the Explainer. I mean, I literally cannot believe we are finally here. Welcome to Part 100, the absolute grand finale of our ICD-10-CM Guidelines series. Today, we're taking everything, and I mean everything, we've learned from sections I, 2, 3, and 4 of the official CMS guidelines, and we're synthesizing it into pure executable mastery. We are going to lock in those core principles you need not just to ace your board exams, but to absolutely dominate your career. If you're ready to conquer the complexities of healthcare data and totally transform your future, well, you're in exactly the right place. But before we get into the heavy technical rules, we gotta establish our mindset, right? Consider this core philosophy straight from our source material. Coders are the fraud squad. We optimize, but never maximize. I love that. It's the bedrock of being a professional medical coder. We aren't just, blindly typing numbers into a system. No way. We're objective detectives abstracting clinical documentation. We make sure providers get paid exactly what they earned for the services they actually documented. Nothing more, nothing less. Our integrity? It's the absolute foundation of the whole healthcare reimbursement system. Okay, let's dive into this. So why are we working so insanely hard to master all these guidelines? Well, the answer looks a lot like $55,963. According to the AAPC, that is the average salary for a credentialed medical coder. But hey, that's just the starting line. The Bureau of Labor Statistics projects an 8% job growth for health information specialists, which is way faster than average. With an aging population needing more medical services, there is this massive, ongoing demand for experts who can accurately translate those services into claims. It's huge. Here's our game plan for today's grand finale. First, career mastery. Second, ICD and CPT basics. Third, accurate coding steps. Fourth, the 10 commandments. And fifth, principal diagnosis and exam execution. All right, let's kick things off with Section 1, career mastery beyond the exam. Look, passing your certification exam is a massive achievement, absolutely. But like I said, it's really just the starting line. I want you to see how the foundational guideline knowledge we're reviewing today scales up into a lifelong, highly lucrative career. You don't have to stay an entry-level coder forever, unless you want to, of course. You start as a certified coder, mastering these rules. From there, your expertise lets you level up to a chart auditor, where you're ensuring compliance and catching errors. Then, that deep clinical understanding, it can transition you into a clinical documentation improvement, or CDI specialist, where you're literally educating physicians on how to document better. Ultimately, this exact knowledge base is what propels you into becoming a healthcare operations leader, managing entire revenue cycles. The whole shebang starts right here with the guidelines. Moving right along to Section 2, ICD and CPT basics. To successfully navigate a medical record, you absolutely have to know which codebook to use and when. Now, it sounds super simple, but getting this mixed up under the immense pressure of an exam is a classic pitfall. Think of these as two completely different languages. ICD-10-CM is the language of diagnoses and conditions. Basically, it answers the question, what is wrong with the patient, or why are they here? CPT, on the flip side, is the language of procedures and services. It answers, what did the provider actually do to treat the patient? You use your ICD code to justify the medical necessity of the CPT procedure. Never, ever confuse the two. That brings us to Section 3, the steps to accurate coding. The CMS guidelines outline a very specific, non-negotiable methodology for finding a code. If you try to take shortcuts, especially on exam day, you are going to fall into traps designed specifically to catch you. So here is that rock-solid 4-step process. First, identify the main term in the diagnostic statement. Second, locate that main term in the alphabetic index. Third, and this is absolutely crucial, you must verify that code in the tabular list. Finally, step 4, assign the code to the highest level of specificity, applying any required 7th character extensions, using a placeholder X if you need to. Listen, skipping these steps leads straight to cognitive overload, and worse, incorrect coding. And this brilliantly illustrates the absolute golden rule of medical coding. The alphabetic index, it's really just your search engine, kind of like Google. But the tabular list is the actual rulebook. It's the final judge and jury. The guidelines explicitly state that you must never ever code directly from the index. Sure, the index might give you a default code, but only the tabular list contains the instructional notations, like code first or use additional code, that dictate your final legal code sequence. All right, gear up for Section 4, the 10 Commandments of ICD-10-CM Coding. Okay, take a deep breath, These are the universal, rapid-fire rules synthesized directly from CMS that govern all 21 chapters. If you master these 10 rules, you can code pretty much anything. Let's rip through the first 5. Number 1, always verify in the tabular list, just like we talked about. 2, manifestation codes listed in brackets in the index can literally never be sequenced as primary. 3, always assign built-in combination codes, like a single code for a diagnosis and its symptom, instead of unbundling them. 4, honor the automatic causal with presumption. For instance, if the documentation says diabetes with neuropathy, the guidelines automatically presume a cause and effect relationship. And 5, you must strictly differentiate between inpatient and outpatient coding rules. Let's actually expand on that 5th commandment for a second, because this is a massive topic for the exams. Look at the strict difference here. In an inpatient hospital setting, if a diagnosis is documented at the time of discharge as suspected or rule out, you code it as if it exists. But in an outpatient setting, you do the exact opposite. You never code a rule out or suspected condition. You only code the documented signs and symptoms to the highest degree of certainty known at the time of that encounter. Total game changer to keep those straight. Moving on to the final 5 commandments. Number 6, master those 7th characters for injuries. A for active care, D for subsequent, and S for sequela. 7, always report required secondary Z codes like BMI, weeks of gestation, or social determinants of health, because those heavily impact risk adjustment. 8, follow mandatory tabular notes like code first over your own clinical intuition. Always follow the book. 9, apply UHDDS rules, that's the Uniform Hospital Discharge Dataset, for inpatient principal diagnoses. And 10, verify present on admission, or POA indicators. Knowing if a condition was present marked with a Y or not present marked with an N protects hospitals against massive financial penalties for hospital-acquired conditions. And finally, Section 5, Principal Diagnosis and Exam Execution. Now we're merging these high-level guideline rules with the concrete tactical strategies you actually need on exam day for your CPC, CCS, or CIC to snag that credential. So the absolute anchor of inpatient facility coding is the principal diagnosis. By definition, this is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Basically, everything in a hospital's reimbursement, the entire MSDRG payment system, revolves around selecting this single code correctly, based directly on Section 2 of the official guidelines, which naturally leads us to a classic, super tricky exam scenario, and honestly, a reality you'll face on the job all the time. What happens when a patient is admitted and there are 2 interrelated conditions that both equally meet the definition for a principal diagnosis? How in the world do you choose? Well, here is the objective CMS guideline answer. Either condition may be sequenced first. Yep, that's it. Unless the circumstances of the admission, the therapy provided, or a specific tabular note directs otherwise, you can pick either one. Just remember, ethical coding relies strictly on the official, published rules, not on guessing which code might pay out a little more. Now, let's talk about the actual day of your exam. These board exams, they're absolute marathons of mental stamina. So your pacing framework is vital. You have a maximum of 2 minutes per question. Use the codes first process of elimination. Meaning, look at the multiple choice answers first, look up those specific codes in the tabular list, and instantly eliminate the ones that violate the guidelines. Skip the hardest questions on your first pass so you don't burn through your time. Just keep your cool, trust your process, and rely heavily on the guidelines we just covered. And guys, that brings us to the end of Part 100. Healthcare is constantly evolving, but the need for ethical, brilliant coders, that is permanent. So, are you ready to be the expert who decodes these complex mysteries and protects the integrity of the entire system? I want to sincerely thank this incredible global community of learners for being with me on this massive journey through the guidelines. Keep mastering the rules, keep optimizing, and go conquer those exams in your careers. Thanks for learning with the Explainer.